Borodo. My name is Tijani Mohamed Borodo. I'm the first Vice President of IOD, and I'm here to represent Madam President, Dr. Ije Jidemma. Now, unfortunately, Madam President cannot be here with us physically. She sends her sincere apologies for not being here because she's right now at Kigali attending the Commonwealth Heads of Government meetings. She's there officially along with the DG and other members of the IOD. But she's here with us in spirit, and she has asked me to kindly deliver her opening address. So without much ado, may I deliver the opening address by Madam President. Whatever you find correct in the address is from Madam President. If there are any errors or mistakes, they are from me. Forgive me. So I now present the opening address by Madam President. It says, opening address by Dr. Mrs. Ije Jidemma, FIOD, President and Chairman of the Governing Council, Institute of Directors, Nigeria, at the Health and Social Security Committee webinar held on Wednesday, 22nd June 2022 on the Zoom platform at 3 p.m. Distinguished past presidents, members of the Governing Council, and Executive Committee of the Institute here present. Chairman, Health and Social Security Committee, Mr. Nnamdi Okafo, MIOD. Our panelists, Dr. Itunu Akinware, MIOD, Managing Director, Medbury Medical Services, Professor Emiola O. Olapade Olapo, FAS, Consultant Urologist, University College Hospital, Dr. Utechukwu Shagaya, Head and Chief Consultant, Clinical and Radiation Oncologist, National Hospital, Dr. Antonia Shomimo, FWAC, FMCR, Consultant Clinical and Radiation Oncologist. Fellows and members of IOD, gentlemen of the press, ladies and gentlemen. It gives me great pleasure to join the chairman of the Health and Social Security Committee, Mr. Nnamdi Okafo, MIOD, to welcome you all on behalf of the Governing Council of the Institute of Directors, Nigeria, to this enlightening event. This webinar is part of the initiative of the Health and Social Security Committee of the Institute to promote healthy living for and among members and non-members of the Institute alike. The theme of this webinar is prevention and management of common cancers. This is coming at a time when the rate of cancer cases in our country is rising rapidly. The World Health Organization, WHO, in 2018 reported that 18 million people live with cancer worldwide, and that 12.5% of all deaths globally are attributed to cancer. It is alarming to note that these numbers, unfortunately, have been on the increase on a yearly basis. In 2020, an estimated 125,000 people were diagnosed with cancer in Nigeria, with almost 79,000 deaths recorded from the ailment. Cancer is a public health problem worldwide, which affects all categories of persons, irrespective of status, age, or gender. The reality, however, is that the health system in many low and middle-income countries are least prepared to manage the disease. Therefore, a considerable number of cancer patients do not have access to timely and quality diagnosis and treatment. In addition, there's also the problem of extreme shortages of facilities, diagnostic services, and trained healthcare professionals to manage the ailment. The most common type of cancer found in the country is the breast cancer, which kills about half of women diagnosed with the disease. This is immediately followed by prostate and cervical cancer. While many people diagnosed with cancer begin their medical treatment, most are forced to stop midway because of the high cost of treatment and care. In fact, some people consider cancer an illness for the rich or a death sentence because the cost of treatment is exorbitant. Today, Nigeria can only boast of 10 radiation therapy machines across the country, while medical insurance in Nigeria does not cover cancer care comprehensively. This makes it very challenging to keep population in a healthy state, and is particularly difficult for people with cancer or other chronic diseases. This webinar is therefore a welcome development. I do hope that the three esteemed panelists will educate our audience on healthy living to prevent this dreaded disease, and also provide a good alternative for proper management of the ailment. IT is also important to draw the attention of government through the various health ministries at all levels of government and other related agencies to devise an actionable strategy that will drive a more robust awareness on the dangers of common cancers and how to prevent them. Ladies and gentlemen, let me again thank the IOD Health and Social Security Committee, led by the chairman, Mr. Nnamdi Okafor, FIOD, for putting this webinar together and bringing in specialists in the health sector who will give us the needed enlightenment and preventive measures we can take to reduce the chances of getting the disease. Let me assure you all that the Institute will continue to support initiatives that will help improve healthcare for its members and for the overall development of the Nigerian economy. I look forward to an enlightening session, and I thank you all for your kind attention. Dr. Mrs. Ijejidema, FRD, President and Chairman of Council, Institute of Directors, Nigeria, Wednesday, 22nd June 2022. Thank you for listening. I've delivered, as I said, any mistakes they are mine. Whatever is correct from Madam President. Thank you very much for listening.
Thank you so much to our very able first Vice President, Alhaji Tijani Borodo. That was very, very good, and we didn't see any mistakes at all. Everything went very well, and thank you for that opening. It was really well done on behalf of the. We are glad to hear that they are in Kigali now. What they are doing is really, really important. We really wish them a successful outing as well. So I would invite Mr. Nnamdi Okafor to give us his opening address as the chairman of the Health and Social Committee of the IOD. Mr. Nnamdi Okafor, sir, please, over to you.
Thank you very much, Dr. Itinu. And good evening, distinguished ladies and gentlemen, and welcome to the first in the series of webinars planned by the Health and Social Security Committee of the of the Institute of Directors, Nigeria. We are indeed very delighted to have you here, and it is our hope that your time with us this evening will be rewarding. First off, let me thank our able first Vice President, who has so eloquently delivered the speech of our President and the Chairman of the Governing Council of the Institute. Very well appreciated. Your time as well appreciated. We have, in recent past, held some webinars on some health conditions like mental health, COVID-19, cardiovascular diseases. But as you know already, today we are going to be talking about what perhaps is the most dreaded of all diseases, cancer. To do justice to this important topic, we have assembled a very distinguished panel of experts. The President, in her speech, had tried to introduce them, but I believe that they will be formally introduced soon by Dr. Itinu. But before then, I want to thank them for honoring our invitation to speak. We know that they are all very, very healthy persons. As we all know, cancer is one very threatening and emotional roller coaster that no one wants to take the ride. From the data and statistics already released by Madam President, we can see that it's a very serious issue, and that you don't need to go far to find one baby, one son, one daughter, one wife, one husband out there who is battling with this condition. And that is why we have decided to assemble this team this evening to talk to us about how we can avoid this condition. And on the unfortunate event that you are battling with it already, how you can better manage it. Of course, if you have any close relation, in this condition, we believe it will be very useful to you. Distinguished ladies and gentlemen, I have no doubt that we are going to leave today with some very useful, life-saving information. But what will be most fulfilling to us is what you do with the information after today. It is our expectation that lives will be saved as a result of this webinar. Let me once again thank all of you for being here. Thank you very much.
Thank you very much, Mr. Nnamdi Okafor. That was a great introduction. And without much ado, I'm just going to go into today's webinar. First of all, I want to invite everybody again who has joined, who is on the group now, all the participants that have decided to join us today for this webinar. And it's really a pleasure for me to be here. And I must also thank the leadership of the Institute of Directors, specifically the Committee for Health and Social Security, because this is such a very interesting and important topic. And as you have mentioned, Mr. Okafor, the truth is that there's nobody on this panel now that has not come across, been involved or been affected by cancer. Perhaps someone who is a loved one, a family member or a friend, or even somebody that works in the organization. And the interesting thing and the troubling thing about cancer is that it's not going down. The data shows us that it continues to increase in terms of the incidence of cancer. And as our lifestyle changes, we expect that the incidence will continue to go up. Now, a lot of people want to bury their heads in the sand and say, oh, it's not my portion, this will not come my way. But the truth is that what we really need to do is to face it, understand the risk factors, understand what we can do to prevent it if that is possible. And as you mentioned, sir, for those that have been diagnosed with it, how can they get treatment options? What are the things that they need to do? Also, we are hoping that in this webinar, we'll come to see what we can do to even prevent the scourge of cancer within our environment, as an individual, in our organizations, in our associations. So I welcome everybody again. It's going to be a very interesting 90 to 120-minute session. So, and what also makes me very excited today is because of the crop of the experts that we have invited. We have brought in the best of the best of the best across Nigeria, from Lutz to UCH to the National Hospital Abuja. It's my great privilege and honor to be sitting with such great minds that have done a lot in cancer research and cancer treatment across Nigeria. So I'm going to be speaking and introducing them very briefly, but again, I'll introduce them again just before their presentations. But before I do that, I'll speak about what we are going to be doing today. So today we are going to it's going to be a stepwise journey where we start by really understanding what cancer is. There's going to be an introduction to cancer. One of our speakers is going to take us through the different types of common cancers. And then when we are done with that, then we'll hone in into the detail of some of the commonest cancers that we have. First of all, starting with the cancers that affect women, which will be specifically speaking about breast cancer in detail. And then we'll speak also about the cancers that affect men with a specific focus on prostate cancer. Afterwards, we are going to be taking the question and answer session. I believe it's going to be very engaging. As our presenters go on, please drop your questions in the chat box. There's going to be a Q&A chat box. Please drop all your questions, comments in there as much as possible during the Q&A session. We are going to have an interactive session and we're going to be able to address it all. Now, it's an honor to be able to introduce Dr. Shagaya. Dr. Uchechukwu Shagaya, she's a consultant clinical oncologist, and she's the head of radiotherapy and oncology from the department of, head of the radiotherapy and oncology department at the National Hospital Abuja. As I mentioned, we have the best of the best in our midst. She's a member of the African Cancer Coalition, and she's also involved in writing the guidelines for the treatment and the management of across sub-Saharan Africa. You are very, very welcome, Dr. Shagaya. She's going to be taking us through our first presentation, where she gives us an introduction into cancer, as well as the common cancers we have and the things that we can do to prevent it and to, as well as to treat them. After Dr. Shagaya's presentation, we'll be going into the second presentation, which will be speaking a bit more, giving a bit more detail to breast cancer. And that will be taken by Dr. Antonia Shoni. She's a consultant clinical and radiation oncologist from the Lagos University Teaching Hospital, LUTH. She's the first female clinical radiation oncologist, pioneer female clinical radiation oncologist, which is fantastic and fabulous, right? She's had over 20 years experience in the oncology environment. She's very keen. She has a keen interest in research, and she has won various awards locally and internationally for her work in the oncology space. And last but not the least, we'll be closing up the presentation session with the presentation by Professor Emiola Olapade Olaopa. He is a professor and consultant urologist with a special focus on prostate cancer. He's a professor of surgery at the University of Ibadan, UCH, the premier university, and he's also the immediate past provost of the College of Medicine of UCH. He has done a lot of work in prevention, a lot of work in research, a lot of work even in genetics, and coming up with the new treatments that we have for cancer today. So as I mentioned earlier, we have the best of the best minds, and this is going to be one of a very, very interesting session. Thank you all for joining again. We hope that you'll be with us throughout the whole session. Please drop your questions and answers in the chat box, and we'll be able to answer that as we go ahead. So without further ado, I'm going to invite to speak to us now, Dr. Shagaya, who will be taking the first presentation. You're welcome, ma'am.
Good afternoon, Dr. Itino, and good afternoon, everyone. I feel extremely honored to be in your midst. I'm seeing some of my teachers and people that I really feel honored to be given the opportunity to come and share my talk with you. Without wasting time, I would like to start, but I probably should greet the Mr. President, Mr. Vice President, the past president, and all the, I'm just in awe of your presence. But I'm more in awe because for the first time, I'm going to be talking to people who I know will be able to make a difference. It's one thing to have these health talks, but it's a different thing to be having the health talks to a caliber of people who can do something. So let's hit the ground running. The topic is reducing the cancer scourge. Let me show myself. Okay, so reducing the scourge of cancer in Nigeria, basically. So, Okay. So what exactly do we know about cancer? The questions I'm going to be going through are, what do we know about cancer? What is cancer? Who gets cancer? And how serious is this problem? And what really can be done to ameliorate the problem? A lot of us know about the information, cancer being a major public health. So I don't really want a problem. I don't want to go, I will skip over some of these slides and then we'll get to the areas where we can really, make a difference. Our figures in Africa changing? Yes. We're beginning to see figures. Before, a few years ago, 20 years ago, cancer really wasn't a disease that we were diagnosing here. Was this because we didn't have cancer? We didn't have the means to diagnose it, or we didn't have the know-how? But we're also beginning to change our lifestyles. We're becoming more like the Westerners, adopting their lifestyles, and it's also coming with their own problems, cancer being one of them. Between now and 2030, if we don't have any intervention, we're expecting 11 million people to die of cancer. This is WHO's projection. This is a major problem. But basically, how does cancer start? It starts from one single cell. I always give an analogy. Imagine if you're in a hall, in a party, and one child is disturbing the general area. Initially, the adult beside the child will, pick up the phone and say, to the child. If the mother is not able to contain the child's misbehavior, the people in the front row are going to turn back. And before you know what's happening, that whole area will be disturbed. If that child gets up from that seat and runs to that extreme end of the hall, at this point, the people on the other side are also looking at that child. This is basically how cancer cells behave. They have the ability to irritate the local area, and they have the ability to distort the event of the body. So when we talk about metastasis and spread, it is that child jumping from one end to the other end. If at the time when the child is just, making noise in one corner, you're able to get that child, maybe an usher, ask the child to step out, and the mother, you actually will be able to continue your event without that disturbance. I'll explain how this is relevant as we go along. So normally there's the interaction between the person's genetic factors. This is the one where you hear them talk about they have a family history of cancer. Or in that family, they tend to have cancers. This is a genetic one. There's not much you can do about this. You're born that way, you can't change it. But we have the external factors, which are the physical carcinogens, ultraviolet light, ionizing radiation. You and I may not have the same exposure, but ultraviolet light, we're all exposed to the sun. Many of us are more particular about the sun in people, the albinos, but I tell you, we need to use sunscreen. We need to keep away from the sun. Don't just walk. I don't expect directors to really be so exposed to the sun, except for those who maybe out in the field or for supervisory roles. But you can have policies and things about sun protection. Ionizing radiation, I as a radiation oncologist, I'm exposed to things like this. In the hospitals, there will be signs telling about ionizing radiation, but sometimes, we have people walk into hospitals. They see the sign, but, you don't think anything of it. It's quite important. The ionizing radiation in a hospital setting and also in, mining, you might be exposed to things like this. Can you hear me? Does it sound okay?
Yes, you're very okay, please. You're very okay. Yeah,
all right, then we have the chemical carcinogens, components of tobacco smoke, aflatoxin. This can be a food contaminant. It's great for those who store grains. They're not stored in a dry place, you can easily get infected. And then arsenic, which is a water contaminant. The ones we can really do much about are the biological carcinogens, where we have some viruses, bacteria, or parasites. So before I go further, let me show you what cancer looks like. For me and Dr. Shomi and Prof, we're used to these things. So they're a bit gory, but I want us to look the enemy in the eye and figure out what to do. This is a picture of a woman with breast cancer. This is another 35-year-old. This is a child. You see children, in the traffic, you see people like this with things like this, begging. This is a type of cancer. You can see the thyroid there. And next slide. That's the prostate gland. I will explain a bit later. So cancer is not one disease like most people tend to think. It's a disease of over 200 different diseases, but they have two major characteristics that they share. One of them is that they have the ability to multiply for no reason, and they refuse to stop multiplying, and they have the ability to move from one end to the other. This is where we use the word metastasis as doctors. These cells are different in the sense that they keep on this multiplication with the sole aim of just taking over the body. They are immortal generally, and they continue to multiply until they kill the host, which is why it is such a scary thing. Who gets cancer? Infants, children, young adults, middle-aged people, old people, women, men. Every part of the body can have cancer, and every human being is subject to this horrible disease. Like as I said, I'm not going to go into the statistics. We already know it's a problem. We know that, we have late presentation in Nigeria or in Africa. Next slide. So who are the 6 most common cancers in Nigeria? We have cancer of the breast, and then the cervix. The cervix is the neck of the womb. We have cancer of the prostate. We have cancer of the colon and rectum. Those are the intestines, cancer of the liver, and non-Hodgkin's lymphoma. Down south, they tend to say breast cancer is more common in the females. Up north, we tend to think that it is cancer of the cervix. The literature sometimes is conflicting, but I think overall breast cancer is probably the most common cancer in females. So why do we think cancer is increasing in Nigeria? There's a poor awareness of the risk factors, because I tell you, there's no oncologist that knows what causes cancer. But we do know the certain behaviors that have been studied, that among people who have those behaviors, cancer is common. Let me repeat myself. We don't know what causes cancer most of the time, but we know certain behaviors that have been associated with an increased risk of cancer. These are called risk factors. One of them is our change in our lifestyle from our more rural lifestyle to the more urban Western lifestyle and diet. Our grandparents walked to the farm, they ate organic food, like literally farm food that they farmed. There was no processed food and all that. And there are many other things that we'll talk about as we go along. Next. Now, WHO reports that 1/3 of all cancers can be prevented. Another third can be cured if caught early. So we're basically saying that 2/3 of cancer, there's something you can do. And 2/3 of any figure from where I come from is a pass mark. So it means that in as much as cancer is a horrible diagnosis, if we go about it the right way, it is not as sinister as it might sound. So what can you and I do? What can my church do, or my mosque, or my government, or in this institution, this discussion, this webinar, what can this group of directors do? Next. The first thing I will talk about is reduction in tobacco consumption. You have, I beg your pardon?
Sorry, is an interference.
Oh, okay, okay. Sorry.
Mute the person speaking, please.
So a reduction of tobacco smoking. If you are a smoker, please reduce and aim to stop. If you have staff that are smoking, encourage them to stop, give them incentives, make your offices, your companies, make them no smoking areas. This is the single most important avoidable cancer risk. Single most important avoidable cancer risk. I always tell people, I say, you know what, there are certain things, certain cancers that you cannot prevent. I mean, if you have a genetic predisposition, there's very little you can do with some of them. But if there's a situation where you can actually, it's like an investment, why not take advantage of it? You already know that, look, if I do this, then I've reduced my chances of certain, exposures and certain. So first-hand smoking, second-hand smoking is a no-no. It's something we really must think about, Next. A healthy lifestyle and diet can help. I tell, my patients come to the clinic, sometimes someone in the family has been diagnosed with cancer, and then they go on a spree. Carrot juice, broccoli, cauliflower, beetroot. And I always say to them, please let us do things that are sustainable and things that are reasonable. I mean, if you lived on the plateau, it's easy for you to have access to all those vegetables. But if you live some little village, down south, you might not have access to beetroot. or broccoli. But guess what? God has blessed Nigeria in such a way that we still have the greens. We have vegetables. We've got fresh things. So let us incorporate that into our lifestyle. Physical activity. Now, this is where the directors, I think this may be quite relevant. I imagine that most of you are driven to work and driven back. And most of your work may not be so physically oriented. It's more cerebral, meaning that it's your brain you're using to work. As a result, the sedentary kind of lifestyle might creep up on you without you realizing it. Physical activity is extremely important. 30 minutes brisk activity of brisk or purposeful exercise for 30 minutes, 3 times a day is extremely important. I will give you next slide. It's not difficult to do these things I have just said. In addition to those other things, there are some diseases of cancers that can be prevented, while some can't be prevented. So let us push our minds towards the areas that we can prevent. Okay, and the ones top on the list are people like the breast cancer, prostate cancer, the intestinal cancer, and cervical cancer. These are the ones that you can catch them in either a pre-cancerous stage and do something about it. So why not make sure you have checked the boxes of all these ones in your life and in the lives of your loved ones? Next slide. Now, I understand, when you give these medical talks, it gets boring. Sometimes people even fall asleep. If you're not going to remember anything I say, the next 2 slides are probably my 2 most important slides, okay? It's the 7 danger warning signs of cancer. It spells out the word caution. Caution, like, danger. The C is a change in bowel habits. If you suddenly notice that you used to go to the loo to move your bowel once every day, all of a sudden now you're going once in 4 days, it's significant. Either an increase or a decrease in the bowel habits is significant. A sore that will not heal, no matter where the location of this sore, a sore or a wound that will not heal. You're not diabetic, or even if you're diabetic, you just have this sore, that, off and on, you go to the hospital, it's important. Get a doctor to look at it. Unusual discharge or bleeding from any orifice or anywhere on the body, even if it's just under the skin. If it's an unusual discharge or bleeding, it's significant. Thickness or lump in the breast or anywhere in the body. If you have a thickness, any lump, anywhere, be it in your abdomen, your thigh, any thickness or lump is significant. Let the doctor be the one to tell you that, oh, it's a lipoma, or no, it's fine. Or we'll take it out and the pathologist says there's nothing. Please, it's high index of suspicion vis-a-vis, it's not my portion, is the worst way to go when it comes to cancers. When it comes to cancers, you are better off erring on the side of caution where you are worried, and then you go to the doctor, you tell them, I want you to check this. I want to make sure it is not a cancer. And then let the specialist be the one to tell you, you're fine, you have nothing to worry about. Indigestion or difficulty in swallowing. All of a sudden you notice you eat food after 6 p.m., your tummy doesn't digest, or you feel bloated. This is significant. Or difficulty in swallowing. All of a sudden you notice that it's easier for you to eat light, your tuwo or your amala has to be very, soft. When you have to swallow, it's difficult. Significant, please seek appropriate care. Obvious changes in moles or warts, or even birthmarks. People who are very fair skinned, or even regular people, you have this abnormal patch that you might have been born with. If you notice over the years, all of a sudden it starts to itch, or it gets raised, or it starts to bleed, or it changes in any manner or color, please see a doctor and let them look at it. A nagging cough or hoarseness, when you start to come on, a funny voice. Sometimes you might have gone for, those who are politicians, they've gone for their, what are they called? Campaigns, they've used their voices, or the men of God have used their voice, or in the choir. It's okay, once in a while you can have a hoarse voice, but a persistent hoarse voice is significant. You should seek help. So I go back in saying that the word caution, even if you don't remember anything I'm going to say, these 7 danger signs are sufficient. At least it will make a whole lot of difference if you share this with everybody, 2 or 3 people. Next slide. Next slide. So the Mayo Clinic, which is one of the big clinics that in the world that have done a lot of research, they have certain advice that they've given, which I want to make sure I share. 1, maintain a healthy weight. Gone are the days when we used to say, when you look big and nice and you're healthy, weight is not your friend. You want to be the right weight for your height. Learn those 7 warning signs I just talked about. Protect yourself from the sun. Use sunscreen for ladies in particular, not just for beauty and aesthetics, for protection from cancer of the skin. Try to aim to use at least SPF 50. This will protect your skin from aging as well as from the damaging rays of the sun. Avoid the midday sun, stay in the shade, cover your exposed areas, and use a good sunscreen. I already said that. Get immunized against hepatitis B. Hepatitis B has been implicated in the etiology of liver cancer. And this is one of the viruses that you can actually vaccinate yourself against and reduce your chances of ever having liver cancer. It's an investment that you want to do, even if you can't do it for yourself, children, grandchildren, staff. It's something, and it's something that is, hepatitis B is extremely contagious. It is sexually transmitted, but it's one of those things that, you want to be careful about. So getting immunized against hepatitis B is something we want to talk about. Next slide. Cervical cancer is another one. Remember the cervix, I mentioned it before, that's the neck of the womb. It has been associated with something called the human papilloma virus. It's also sexually transmitted. It is, there's now a vaccine that if you're able to get your children immunized against HPV, you reduce their chances of them having not just cancer of sex, but many other cancers. And I'll tell you those cancers in a few minutes. But the catch in it is that, like I tell people sometimes, parents, we wake up and we work our whole lives. We want to leave land for our children. We want to leave property for our children. Health is wealth. If you're able to get your sons and daughters immunized against human papilloma virus, it's like an investment. So it's something that I don't want us to take for granted. When science is able to do things like this for us, please, we must jump on that train and take advantage of it. Next slide. For women, learn how to examine your breast. You have to perform it once a month after your cycle. Stand in front of the mirror, look at your breast. Are they the same size? Some of us have one breast bigger than the other. That's normal. But you want to look at them. Are they now pointing in different directions? Use one hand, the right hand, to examine the left. Use the left hand to examine the right breast. You are looking for any abnormal lumps or anything that was not there before. Get a pelvic examination. And while you're doing the breast examination, also check the armpits, the underarms. It's something you do after your cycle. Because before the cycle, the breast might be a bit tender and you're not able to really get out the feeling. A pelvic exam should be done by mature childbearing women once a year, a pap smear once a year. And once you've done 3 consecutive pap smears and they're normal, you can afford to do it every 3 years. Get your daughters vaccinated against HPV, please. For men, the men should check their PSA from age 45 and then annually afterwards. And I can say this from experience, most men hate to get a digital rectal exam. But like as I said, health is wealth. The same men want to buy land for their family. They want to buy land for their first son. Keep yourself healthy. All you have to do is do the blood test and get a urologist to do a rectal exam on you. A PSA is not enough, because I find sometimes some people just go and do a blood test, forgetting that a doctor doesn't treat just blood results. You treat the patient. So we need you to get a rectal exam done as well as the PSA. Avoid smoking, exercise for 30 minutes 3 times a week, and then have a colonoscopy or at least a sigmoidoscopy. What is this a colonoscopy about? I talked about cancer of the intestines being a common cancer, right? All you do is, it's like a torchlight and a pipe that they use. They go through underneath that anus and they look through your intestine and look for any abnormality. Why is it important? This is a test that is normally done for maybe age 60, and you have to do it only once every 10 years. Cancer of the colon is one of those few cancers that if you catch it early, you do surgery and you are fine. You don't need to do chemotherapy, you don't need to do anything. Cancer management, when it's caught early, most of the time is so much cheaper and easier, more tolerable than when it is caught late. For those people who have a family history of cancer of the intestines, their own colonoscopy may be indicated slightly earlier than the regular population. Help create awareness. My esteemed directors, how can you help with this creating of this awareness? Lectures like this, I was approached by you people. If you go into your various institutions and you support things like this type of lecture, you'd be amazed. Publication, I'm a doctor, I do a bit of research, and I know in the house, there'll be people who are either involved in media, journalism, and all that. You throw in a publication every so often about things like this, you'll be amazed. Sometimes the public listen more to you than even the doctors. If you help to disseminate information like this, you'll be amazed. Sponsor free clinics in the villages. Pap smear, breast examination, rectal exam, and PSA. Sponsor things like this. Just the association, you go to the grassroots, because generally people in the urban areas may know a little bit more. You can support on the radio shows, on the TV shows, chants where they're talking about cancer and all that. You'll be amazed how much this information will infiltrate the people, and people will now begin to talk about things, you know. Next. Donate a mammography machine to the central hospital where closest to you. Mammography is breast cancer is one of the screenable cancers. When I mean screenable, I mean a cancer that you can catch before it becomes untreatable. You can donate PSA kits. You can use your influence. You can make the government make policies available that will help patients. You can insist and decide that, you know what, in the 6 geopolitical zones, we want to have full cancer centers. You are influential people. You are not regular people. You are influential and you belong to the upper cadre of society. There's so much you can do with your positions. Then in your corporate social responsibility, you can decide, and I always tell people, sometimes, we talk about starting things like, radiotherapy centers and all that. That is big stuff. But I know you're capable. People have the finances, they just don't know how to channel it. But luckily, because you are well situated, these are things you can begin to think about. You can start small, you can end big, you can start in the middle, wherever. The leaky pipe within the cancer care journey, from diagnosis to palliation, there are holes everywhere. All you have to do is just look for where you want to key in and help. Next. If cancer is found, early treatment from appropriate cancer specialists makes all the difference. You have Dr. Shomi right there with you. You have Prof. Olakwade, and you have people who can really make a difference. I urge people, when by the time you're a director, you are not just a regular person. You are a leader. So if in your various institutions, you make it part of your yearly checks while you're doing your personal evaluation forms or maybe promotions or whatever, you can incultivate your health checks and put some of these cancer screening modalities to be part of it. Next slide. Or when the patient gets a happy birthday message, they are reminded to do a pap smear or their PSA. So without wasting so much time, because I know my seniors in the house have so much more information to give to you. My final word on everything that I've had to say is that the reduction of the cancer scourge in Nigeria is possible. Thank you so much for your time. Today, the easiest answer I'll tell you is prevention and early detection. And this is in your hands and in my hands. Thank you for listening.
Thank you very, very much, Dr. Shadaya. That was very enlightening. Thank you so much for that overview. And I must say that this is the first time I'm hearing this, but it's very instructive. The word caution, the acronym caution for, being able to, check ourselves and know what to look out for. And we're going to hopefully circulate that. We'll talk to the Secretariat to circulate that to everyone on the webinar today. Very excellent session. We all agree. Thank you so, so much. And you've laid a beautiful foundation for the rest of the speakers because you've given us an overview. Now we are going to go to Dr. Showumi, who is going to be speaking to us specifically on female cancers, as well as focusing on breast cancer. Thank you again, Dr. Shagaya. We welcome you, to Dr. Showumi, for your presentation.
Thank you.
Dr. Showumi, I think you are muted. Please, can you unmute? Okay.
Yes, I see that. Okay. Good afternoon, everybody. And I feel so honored being invited to give this awareness talk. I stand on existing protocol, and I appreciate the Institute of Directors for inviting me to help in creating awareness, just like my fellow speakers. And I hope that at the end of the day, we would be able to reach to so many people, and so many that have joined in, they will have something to take home. Dr. Shagaya, you've done a very good, comprehensive, down-to-earth presentation. That was excellent. So this afternoon, I will go straight to breast cancer, which is sorry, I'm trying to get the slide. Okay, I'll talk about breast cancer. Breast cancer, as Dr. Shagai had done a very good overview and introduction, so I will just keep straight. But just to reiterate some of the things she had said, you know, cancer is preventable. You need to note the caution signs, and you and I can make a difference using our positions, using our authorities where we work, being our brothers and our sisters' keeper in ensuring that the scourge of cancer is being reduced. As we all know, cancer now, it's a global public health problem. And there are lots of mystifying facts and myths about it, and a lot of misconception, which honestly, in Nigeria or in Africa, so to speak, we know that we're very superstitious. And because we're superstitious, a lot of these misconceptions need to be corrected. Dr. Shagaya had talked about the common cancers, which are the breast, cervix, prostate, the liver cancer, colon cancer, and the lymph node cancer. Many a times people wonder, and when we quote a lot of statistics, it's like, it's not real. You hear a lot of people say, oh, it's a white man disease. But the truth about it is that we realize that in Nigeria, from some the statistics and researches that have been done, we have over 100,000 new cases that occur every year. And of course, the WHO had also said that a lot of these cancers, with the projections that were made, a lot of them will come from developing countries, Africa, and West Africa. In 2020, about 10 million lives were lost. And the age group just like Dr. Shagaya had spoken earlier on, that it's within most times the reproductive age group. And when you have cancer in the reproductive age group, it has its own repercussions. You find out that a lot of times it affects the economy of the nation. There's a lot of psychological trauma, emotional trauma, financial trauma. In a research that was done sometime in 2004 and 2013, we found out that the mean age of presentation was about 49 years. And of course, that's for the female, and for the male between 50 and 54 years. Coming down to the basics, like I said, we quote statistics at times and it doesn't sound so real to people. At times when budgets are to be presented to policymakers, you find out that so much quoting of the statistics, but when you think of it, just like Dr. Itunu has said, there is nobody that has not heard about cancer, either a relative, a friend, distant or close. And the statistic says 1 in every 5 men and 1 in every 6 women will develop cancer before they get to 75 years old. That's the incidence. So maybe when we look at it that way, it sends a warning sign to us so that we know what to do, we are proactive. When we talk of the mortality, the cause of death, we realize that 1 in every 8 men and 1 in every 12 women will die from the disease. So when you look at it that way, the statistics now drives home to each and every one of us what we're facing and what the scourge is all about. Breast cancer is the commonest female cancer that we have in Nigeria. Globally or worldwide, it's lung cancer that is the first, but in Nigeria. And we see about 570 new cases being diagnosed worldwide. Usually accounts for about 18.4% of all cancers. One thing I would like all of us to note and remember, men also have breast cancer. I'm sure, did I hear people sigh? That's the truth. I have patients that I've treated, that I'm still treating, that are male, that have breast cancer. The only difference is that the incidence is very low. It accounts for about 0.2%. But when you get them, they're very, very aggressive. And that's why we'll say that the men should also examine their breast when they notice anything unusual or a lump there. It's important that you see your doctor and do further examinations and tests to ensure that it's just an ordinary lump. When we talk about the age group in which we see breast cancer, it's between 30 to 50 years that it's common, but also we do not rule out breast cancer in the age group of 20 years. It's rare, but it happens. And the youngest age recorded in Lagos State for breast cancer was a female of 16 years, and this was in 2006. One of the challenges and problems we have with breast cancer is after diagnosis, what next? In developed countries, we'll use the example of United States of America, the survival rate for cancer is 85% when being diagnosed. But in Nigeria, it's just 10%. And there are reasons for that. Lots of factors, and mainly because we know that we don't have, just like the Institute, why they brought up this webinar, it's because we have lack of adequate infrastructure, lack of adequate diagnostic centers and treatment. It's not just discovering, but how about accessibility and affordability and availability of what we need, equipment for the treatment. The previous speaker had said that the cause of cancer, it's largely unknown. And same thing goes, for breast cancer. The only thing that we know is that the behavior of those who have had a particular kind of cancer, the research has been done, and it's been discovered that for each particular kind of cancer, the people who have had it have similar behaviors and characteristics. And that is what we call risk factors. And these risk factors are what helps us in preventing breast or cancer generally. For breast cancer, we have three main factors. We talk about the endocrine, which we also call the hormone factor. We talk about the genetics, and then we talk about the environmental. When we talk about the endocrine or hormonal factor, the age at which a female child starts her menstruation is important, and the age at which she stops is also important. That age of onset or commencement of menstruation to menopause, when it stops, is called the estrogen window. And usually when it's early and it's late, when it's long, you find out that it's a high likelihood that the patient or a person can come down with breast cancer. The age of first pregnancy, a lot of times now we discover that because of people wanting to get educated, having financial independence, we find a lot of female children getting married late. That age of first pregnancy, so most times they end up at times over 30, getting pregnant or having their first child, not because of infertility, but because they want to ensure that they finish their education and they have good jobs before they get married. And that is one thing we try to say. We're not saying they shouldn't read. We're not saying they shouldn't become financially independent, but as soon as possible, it's important that they get married and have their first child early on pregnancy. The number of children you also have has been implicated. Then there's this controversy of contraceptives. People have asked and said, oh, they've had a lot of stories about when you use contraception, you are prone to breast cancer. and I say it's a controversial issue. From research that has been made so far, it's because that particular individual has been on the verge or borderline. So it's not the hormonal contraceptive per se that is causing it. And so it's also important so that at times in this era of family planning, so that people don't avoid and say, I don't want to take contraceptive when they've been advised to because of family planning. We talk about the genetic factor. Breast cancer runs in the family. We have the gene that we talk of, BRCA1 and 2. And of course, it's inherited. Some families have them, and when they do, there's a very high likelihood that they will come down with breast cancer. It skips a generation. It would skip 1 or 2 generations, but at the end of the day, they might come down with breast cancer. And that's why, for some of us who remember, Jolene, the actress, went, and because she has this gene running in her family, she went and had removal of 2 of her breasts and putting a prosthesis there, because the first risk factor is having breast tissues. That's why you have breast cancer. She's white, she's Caucasian, fine. But you know, I'm thinking in this part of the world, nobody will want to have their 2 breasts removed when they haven't had cancer. Even for those who have cancer, when you advise them to remove their breast, a lot of them will tell you that, oh, they don't want to remove their breast, that they've had that if you remove your breast, it's not going to be healed, which is one of the myths and misconception. Some will tell you that when they die, that there's reincarnation, when they're coming back, that they're going to come back with 1 breast. And the question we ask them is that, have you ever seen anybody that comes back with a breast? And some will say they don't want to go and meet their maker in an imperfect state, that is with 1 breast missing. So those are some of the myths and misconceptions that we need to correct. Of course, if you have a family history of breast cancer, you're prone to cancer, especially when it's the 1st degree, very close, maybe like a mother, a very close auntie. Then for some who've had some breast diseases in the past, then there's also that association and correlation of when you have cancer of the womb, which we call endometrial cancer, and then cancer of the ovary. The ovary in the female, it's that organ that releases the eggs, right? So when you have that, there's a possibility, it does not mean that it will happen, but there's a possibility that one could come down with breast cancer. Then for those who have never been pregnant, right, there's also a possibility. We go to the environmental factor. We talk of geographical location. There are times there was a study, people were trying to study that I was looking into, and some were saying some people coming from a particular area are prone to, you know, breast cancer more than the others. That's controversial. But at the same time, maybe there is more to it, because like the previous speaker had spoken, we have, you know, ionizing radiation, maybe because of their lifestyle. Maybe there's something in the environment that keeps emitting radiation and make them prone or susceptible to, you know, cancer. So when you find such things, we need to investigate further. Exposure to ionizing radiation, if we all remember that when they had the nuclear explosion the other day, and even in Nagasaki, where it was, we've had nuclear accidents. Of course, the earth absorbs those radiations. And all those living in that vicinity, in that area, will come down 5, 10, 15, 20 years down the line with cancer. But this is also dependent on every individual's genetic makeup. Some have that immunity in them that can help to fight the disease, while some, they do not. Then alcohol has also been implicated. In most cancers, alcohol and smoking has been implicated. So we should be very cautious of our intake of alcohol. Yes, you can take socially at times, but not the type that every day. There's some people, they take a carton, or at times when they go to parties, when they see free drinks, they can drink a carton at a sitting. I mean, that's disastrous, and that's not good. Of course, we have high social economic status. Why this has been implicated is because it's those who are comfortable that can buy or have changed our diets, our lifestyle to the Western world. Like Dr. Shagaya said, in the past, our forefathers, they were taking organic food, walking to the farm, eating fresh fruits. But over time, we all feel that emulating the Western world, it's fashion. And so we've been taking a lot of processed food, which are not good for us. Of course, obesity and diet for every cancer is always implicated. So we say that breastfeeding is protective against breast cancer. Why this is important is because we realize that nowadays a lot of the young ones feel that they don't want to breastfeed. They want their breast to stand firm. But God, who originally created the breast, created milk, had a purpose. I'll tell you this, children that are breastfed are usually very, very brilliant. So we should please note that it also has its advantage and preventive, protective against breast cancer. What are the signs of breast cancer? Usually, you could find a lump in the breast or in the armpit. You look at, I tell every female that you should know your breast. Every week, maybe once a week, you should look at your breast in the mirror, look at how it looks, the architecture, the size, so that if there's a change, you will detect it and you will observe it early. There could be a change in the size of the breast. There could be a change in the skin. You know, the back of the orange, the way it has these little, dots on it. There are times when you have breast cancer, that are some of the signs that are seen when there's affectation of the skin of the cancer. And of course, when it's advanced, you can find out there is ulcer. Also the nipple, when you examine your breast, you should press your nipple. Usually for some people, especially those who are pregnant or who have had children, yes, you could see when you press your nipple, you could see clear fluid. That's not it. But if you see a colored fluid, you should use either the white tissue or cotton wool to clean whatever is coming out from the nipple. And if you notice it's a little kind of brownish or blood stained, you should do something and go to your doctor. Of course, you could have
hello, doctor.
Yes.
Hello, ma. Also,
Yeah.
sorry to cut. I was really, really enjoying the presentation that even I, just realized now that I think that we are really, really not as well in terms of time, but I don't want to cut you short because I know that what you're saying is really important. So please, if you could just help us with, summarizing or,
Okay, I'll do that.
Yeah, I believe that when we get to the Q&A session, we'll still speak a lot about it, but I'm really enjoying your presentation, ma. Just to let you know, the time is fast spent. Please go on.
So we could have a mass in the armpit. And of course, when it's advanced, like the previous speaker has spoken, you could have it spread to any part of the body. The patient could come down with cough, shortness of breath, yellowness of the eyes. At times, the patient could be in coma. It could spread to the brain. You could have bone fracture, depending. And so what's the treatment? It could be surgery, where you could remove part of the breast, or you remove the whole breast. We have chemotherapy, what we call anti-cancer drugs that we use, their combination. We have radiotherapy, the hormone therapy, and the monoclonal and immunotherapy are new therapies that have less side effects, but they're very expensive. In terms of the radiotherapy, I will say this, that at least we know that we don't have too many of it in the country, and it's something that needs to work on. But I can tell you that at my center, we have so far the best in West Africa. We have 3 machines. We do brachytherapy. So all forms of treatment of radiotherapy can be done, and the price is reasonable. At least it saves a lot of, it has reduced medical tourism and a lot of people. So when it comes to treatment for radiotherapy, you can come to Luth. Of course, screening, it's important that you do mammogram. FI is what we use for screening for breast cancer. And usually they say women between 40 and 44, you really don't have to do, or you could do once a year but from 45 years to 54 years, you should have mammogram done every year. And once you've done it like about 3 years and you're okay, fine, you do it every 2 or 3 years. For women 55 years and older, of course, it's important to do your mammogram as well. And that's the way you can detect. And things that we say you need to know, if you have cancer, people run away and they don't want to, but it's important to have your treatment. When you have your treatment, you know, it helps you, you can survive, you can live your normal lifestyle. The key word here is early presentation is the key to survival and the cure of breast cancer. I always say living is a personal choice. You alone can make or have the right to enjoy your life amidst challenges. So you choose right and forget the myths and everything that people say. You change your lifestyle and you live a healthy exercise. Remember, when you're being diagnosed, a lot of people live in denial. Do not live in denial when diagnosed. Seek for help. A closed mouth is a closed destiny. Don't hide anything. The people are there to help you. Health is wealth. The key to cancer cure is early presentation. And finally, I will say knowledge is half the battle. That's why you are here. You can educate others, and action is the other half. And you can see this and see that it's real. These are some of the cases that we see. Over 70% of our patients coming in advanced stages like this, they probably would have gone to either religious healer, use alternative medicine, and then by the time they come, they already have metastasis. And of course, all we can do is palliative. So it's important that, like Dr. Shagaya had said, everybody has a role to play. The directors, in terms of sponsoring free clinics and so many things. And some, I'm showing this woman removed her 2 breasts. Some will say, oh, when people remove their breasts, they die. This is a woman who had breast cancer in both breasts because it could spread to the second breast. It starts with 1, but she removed it and she's fine. So knowledge is key. Thank you.
Thank you very much, Dr. Shomi. That was very brilliant. And I can even tell from even the chat box and, you know, the messages dropped on the chat box that there's been some information that we didn't even know about. And I believe that during the Q&A session, we'll be able to engage a bit more. As you said, a closed mouth is a closed destiny. So people must seek help, either help for themselves or their family members. We must spread the word. Cancer is real and it is preventable if caught early. Thank you very, very much. So finally, we are going to be moving to our last speaker, last but not the least, Professor Olaopa, who is a consultant urologist. He's going to be speaking to us on prostate cancer. You are very welcome, sir. Over to you.
Thank you very much. Could I please share my screen? Well, let me thank the Institute of Directors for inviting me to give this talk. I believe it is a very important avenue to reach people of influence. And let me also pay credit to my two previous speakers who have certainly made my job a lot easier, both Dr. Shagai and Dr. Shomi, Dr. Shomi being a very good friend and classmate. I've been asked to focus on common male cancers, specifically looking at prostate. But because my two co-speakers have already done such a wonderful job, I'm just going to go to some highlights. One, to save us time, but two, to make sure that the specifics don't get lost in the generality as far as male cancers are concerned. So the common male cancers are lung, prostate, and colorectal. I'll focus, these are the 7, but those 3 are the most common, as you can see, by a long way. The most important thing about lung cancer is that smoking of any sort, first hand or second hand, is the most important causative agent. And to also know that lung cancer has a very poor survival rate. So this is one of those cancers that you want to detect early, because late stage presentation is the survival is quite poor. Unfortunately, there are no real ways of screening for lung cancer routinely. So high-risk individuals, those who smoke a lot, are advised to have annual CT scans, whereas low or moderate risk individuals are just asked to watch out for the symptoms, as my previous, as the first speaker spoke about. Colorectal cancer, I'm a little partial about because it's often ignored, but it is one disease, as Dr. Shagai and Dr. Shomi mentioned, that is truly preventable. Its cause is preventable because once it's detected early, then through colonoscopy, as has been said, which is using a small fiber optic tube to try and see if there are any polyps in the large intestine. If this is removed, certainly near cure is guaranteed without any further treatment, and sometimes just chemotherapy and radiotherapy. And this is one of those cancers that is amenable to early detection, whilst if it is not detected early, the converse is the case. So there should be a lot of focus on it. And the risk factors are known: age, tobacco use, obesity, and in some instances, familial history. So this is one cancer that shouldn't be ignored. Of course, we also know that diet high in fat may contribute to this. As has been mentioned, watch out for changes in bowel habits or abdominal girth. Some do present just with low blood counts. So regular blood checks are fine. And as was also mentioned, colonoscopy is only necessary every 10 years in people over the age of 50 years. Most good family doctors know they should do fecal blood tests regularly when you go for your annual checkups. You can reduce your risk of colorectal cancer by getting screened, having a healthy weight and exercise, and ensuring that you eat plenty of vegetables to have good bowel motions and avoiding excesses of tobacco and alcohol. Having said that, I'll go straight to the elephant in the ring, which is prostate cancer. And as I said, I'll only go through the highlights because this is a very different cancer from all the others that we have been talking about, which is why I went through the issue of lung and colorectal cancer. Most people do not know where the prostate is. It is a small gland just below the bladder. And most people also don't know that both men and women have prostate and have the prostate. It's just that it develops only in the man due to hormonal changes. When it enlarges, it causes obstruction of urine in most men. and it is a common focus of cancer. It's important to know that diseases of the prostate are a spectrum. It's not just prostate cancer that affects the prostate, and it is not only prostate cancer that enlarges the prostate. It is not only prostate cancer that causes symptoms. All men, and I emphasize, all men would have enlargement of their prostate starting from the age of 35 years. But only 25 to 50% will ever need treatment. This is a normal aging process and does not in itself progress to cancer. This is the more common presentation of prostatic diseases, not prostate cancer. Cancer of the prostate, on the other hand, is the commonest male cancer. It's just the commonest male cancer. But as I will show in a subsequent slide, if you live long enough as a man, you will have prostate cancer. It is again almost part of the normal aging process and does not cause trouble in most of those men who are affected. Indeed, the statistics are that if you are the risk of having prostate cancer present in your body is the same as your age. If you are 50 years old, you have a 50% chance of having prostate cancer. If you are 70 years old, you have a 70% chance of having prostate cancer. If you are 80 years old, you have prostate cancer. We just may not know about it, or you do not know about it. It's 100%. So both diseases affect all men to certain degrees. It is whether or not they're causing problems that is important. Superimposed on all of that is infection, which may then cause additional issues. The real problem is that prostatic disease may have no symptoms, as I've mentioned. Thank God for that. If all the men with prostate, a prostate, which is half the population, had symptoms, the urologists will do nothing. In fact, there'll be no other doctors. Everybody will be a urologist. But because less than 10% of men eventually need to have something done, is why we're still surviving. So there may be no symptoms. Also, all three conditions, cancer, ordinary enlargement, and infection, will cause an elevated PSA. So no, an elevated PSA does not mean you have prostate cancer, and certainly no, you do not go and just simply get a PSA test because you feel like it. I will show why in a minute. So that is one area I would disagree with Dr. Shigaya. You do not do a PSA just because you feel like. Otherwise, as I will show, you will just be opening a Pandora's box that you might not be able to close. Now, prostate cancer, prostatic enlargement, whether due to infection, ordinary enlargement, or cancer, is most often detected by its obstruction of urine flow, or when you start getting up frequently at night. Occasionally, some people see blood and it may cause symptoms of infection in some men. But generally, the most important thing to know is that there may be no symptoms. And most importantly, if you are worried about anything, you go and see a urologist for him to do the tests. It is true that unfortunately, some men present late and they have sudden problems. Yes, that is true. They may suddenly have issues with walking from backache and all that. But if you ask them, they would have been having other symptoms for a long time without paying attention to it. So I repeat myself. If you have any symptoms of having urological issues, problems with urination, any at all, go and see a urologist for early detection. And yes, as part of your annual study, your GP should do a rectal. Otherwise, just see how things go. Now, a lot of myths are there about prostate in blacks. Yes, it is more common in blacks, but unfortunately, and this is where the IOD come in, a lot of the studies that have been done on US and on African American men. They do not have the say, or they have a different genetic makeup from native African men. So we do know that the disease is just as high, but the behavior is quite different. So we need to know that. We need to do research. My two previous speakers have been talking about IOD contributing to treatment. You can't treat when you don't have research. What we really need is funds to undertake homegrown research that will give us the data that would allow us to advise people appropriately. We should stop all this current nonsense of taking figures from other countries and using it to treat ourselves. I can tell you for free that quite a number of the drugs that have been advertised as being
they don't work.
They don't work with us, or in fact, in
Yes.
certain instances, they cause more trouble because our makeup is different. So what we really need is, yes, the treatment centers, but we need research. So if there's no other slide that you are going to pay attention to, because I'll go through another 10 minutes, I'll be done. Please, this slide is most important. Not all diseases, prostate diseases are cancer. PSA testing does not detect all prostate cancer. As a matter of fact, the cancers you want to be worried about are those that are present in men with normal PSA. So sitting at home because somebody told you your PSA is normal can actually be dangerous. And as I said, a high PSA does not mean prostate cancer. And early testing does not prevent prostate cancer. It just allows us to detect it early. And the problem is, it's not all prostate cancer that needs treatment. So please, this slide is important. I've mentioned this and I'll just go straight. We've been told that genetics, diet, and viral diseases contribute to all cancers. And we've been told that age, ethnicity, and genetics matters. The PSA is a blood test that we use to measure the activity of the prostate. That is what it was designed for. It does not detect prostate cancer. It is secreted by other glands. And actually, women too have PSAs. So we use it to monitor the treatment of prostatic diseases. It is high in all prostatic diseases. So just one PSA test does not mean anything. As a matter of fact, the United States Preventive Services Task Force and all 14 associations that deal with aged men in the United States have come out against routine PSA-based screening for prostate cancer. We're coming on board at the tail end of the game. Now they say you must not do so as a purely screening test because it causes more harms than the possible benefits. And what do we know? We know that it is only one man in 1,000 that would have his life saved just because he had PSA test. But we know 30 to 40 out of these 1,000 men would develop erectile dysfunction. I don't know which African man wants to know that just because he had PSA testing. 2 will have a serious cardiovascular event, and 1 will have a blood clot. So there are harms for prostate cancer with just routine PSA testing. But I always emphasize, I am not talking about people who have symptoms or trouble with urination. Go and see a doctor with that. But just waking up and heading out for one laboratory and doing a PSA testing just because you feel like it on a Sunday afternoon is what we are saying shouldn't be done. And we also know that when it comes to treatment, there are complications. So we restrict testing now in prostate cancer to high-risk groups, people who have a family history. And a family history is a brother or a father who had prostate cancer below the age of 60. Not that your father or brother died of prostate cancer at 110. That is normal. And again, if you are a native African and we know that you have symptoms of urination, we will do a PSA test. And I advise that PSA tests should only be done by urologists only after there have been discussions according to the latest guidelines. You must discuss first with the patient and say, these are the potential problems. Are you ready to accept them? If you are, then we go ahead. What are the other issues? The other issues is that managing prostate cancer is in itself an expensive issue. We know that the patients have a choice of having nothing done. We also know we can just watch. We can also do routine, regular checking of PSAs and rectal examination. But we know that at the end of the day, when you are going to be aggressive in treatment, you are talking about removal of the prostate, which is radical prostatectomy, radiation oncology, which is what Dr. Shomi and Dr. Sagai were talking about, and some other issues. There are, of course, when the disease has spread, systemic therapy, which is giving hormones and also newer and newer drugs. But the new drugs, none of them cures prostate cancer. We always manage, and manage the disease, and there are various regimens to try and delay the mortality from the disease as much as possible. And the first and the most important thing is to time when you start the treatment right. If you do not, you will run out of treatment options and the patient would actually die early. If you actually also just bombard the patient with all the drugs that are available on the market, the patient would also die from the consequences of the treatment itself. Those the drugs we use are actually in themselves quite dangerous. I always tell my patients, we are exchanging one disease for the other. So we must make sure that the benefits of the treatment outweigh the benefits of the disease, and you need a urologist for that. You do not just simply go to ShopRite to get yourself a bunch of systemic therapy and then start taking it. A significant number of patients I know have died from the complications of chemotherapy, because for us in Africa, in Nigeria, we have found that some of the chemotherapeutic agents actually affect us negatively more than they do the whites. We do not know why yet. We haven't done the research, but we know that. Of course, we also know that the good old simple removal of the testes works well, and then there can be other additions. Now, let us look at the costs, because at the end of the day, it is all about cost. If you are going to have radical removal of your prostate, it will cost you about $17,000. If you are going to, my good friends, the radiation oncologists, they're going to be looking at anything from 1.5 to 1.2 million. The other treatments, you can see how expensive they are. Yet, if we just watch you for a few years, it will cost you less than 100,000. If you just remove your kits, it's about 200,000. So I always say each of these treatments has its own place, and the expertise comes in knowing which patient needs what and when. And it is also important to realize that treatment is not treatment of a disease. It is not even treatment of a patient. It is treatment of a person. A man who is 70 years old and has just married, as one of my patients has just married his first wife, did not have any children, and he's just married a young wife, and he's thinking of how to commit his genes to immortality. You detect prostate cancer and you say you are going to remove his orchids. I can assure you that he's likely to send Boko Haram after you. So leave the man to sort himself out, do what he needs to do. Haven't given him all the options, particularly the consequences of all the treatments that we offer. He will then look at his social status and decide what is best for him. And then you would guide him aright. Again, these are just the costs of treatments, just to show that the cost of treating prostate cancer is quite expensive. And at the very bottom, it says the survival difference between simple and complicated treatment on average is 6 months. Yes, people claim that some of these newer drugs give longer lifespan. The problem with prostate cancer is that we are yet to be able to determine who would have died early from the disease or who would have lived with the disease merrily. I give an example of the patient that changed my life, a man who was diagnosed, I diagnosed with metastatic prostate cancer at the age of 68. He had a young wife. He refused my treatment, disappeared, but I called him back. I watched this man for another 5 years before he needed treatment. We modified his treatment over from simple to more complicated. He lived until he was 80. In fact, he just died this December at the age of 82. Now, I don't think you are going to say that even if the cause of death at 82 was prostate cancer, that is an unfulfilled life. And he managed to see his grandchildren. He managed to have a good quality of life. This is what is most important. However, I do recognize, and I always emphasize, that we must spend our time identifying prostatic cancer that is aggressive. is a small cohort of prostate cancer that is aggressive, that we need to be aggressive in treatment, in their treatment. This is where the urologist comes in, but it is definitely not one size fits all. And most importantly, it is definitely not something that you pick off the rack. The issue of prevention, of screening, is that these are the principles. I urge us to look at the fact that a suitable test should be available. Certainly for prostate cancer, we do not have one that is most suitable. And treatment should be more effective if initiated early than during the symptomatic stage. We do not have any figures for that. What we do know is that less men die of metastatic prostate cancer if they're treated early. But the age-specific mortality has not improved, which means that they still die. So what we now want to do is to make sure that the life that they live between diagnosis and death is worth living. There's absolutely no point being alive and being miserable because of the treatment. Because of the treatment. So avoiding death, well, food in moderate quantities, my colleagues have spoken about diet, very important. We cannot say it often enough. The more we go to vegetables, fish, not frying everything that is dead as we do in Nigeria, the more we exercise. There's been a lot, and I know people are going to start chatting me, asking what they said about sex. They were talking about ejaculation. Sex in good quantities is what is advised. It's not that you suddenly take a liberty and you are now having 6 wives instead of 1. Alcohol in small quantities. Tobacco in no quantity. There is no quantity of tobacco that is good for you. And certainly go to the doctor in reasonable quantities. If you keep going to any doctor you can find just to check your PSA, as I often have, then you are going to have consequences to deal with that may not be where you may end up where you do not want to be. And certainly drugs in reasonable quantities. In reasonable quantities. As Dr. Shagaya said, men do not like going to the doctor for any sort of examination. They would even rather go to the tewe tables because those ones don't do any physical and they can keep their secrets secret. We need to increase awareness in the workplace, as has been said by my colleagues, but just to emphasize that because men are worse than women in terms of going to the doctor for annual checkups, and that includes doctors. So with that, I'd like to stop. I believe that I would have addressed some of the issues, and I'm happy for us to take a question and answer. But I must, as a rider, as I spoke to Dr. Akinware, for me, the importance of this particular webinar is that we're talking to directors. They're people of influence. They control significant budget quantities. What we need them to do is not only to worry about their own personal health condition, but to assist with the situation in this country, which is purely abysmal, where 94% of the funds for health research is being funded externally. That is nothing short of shameful. We must take control of developing of the research that we're going to use to treat ourselves, and therefore own the intellectual property that will then allow us to go ahead and develop policies that are good for us. That, to my mind, is the most important part of this webinar. For as long as we are relying on figures from the United States or even figures from studies done by the United States, where they have told us what they want, not what we want, we will continue to have issues of mismatch of treatment policies with the health needs of our society. I thank you.
Thank you so much, Prof. That was not only brilliant, but very down to earth. Extremely down to earth, but again, it's very important for us to hear and listen to the truth. A couple of things you've said now, I've never heard them before. No PSA. Oh, wow, this is really new. Thank you very much.
No PSA. I said no, there's no such thing as a PSA screening just for prostate cancer in a patient that does not, in a man that has no symptoms.
Okay.
That time was, we said, if you are African American or African from the age of 45, go and start doing PSAs. That is gone out of the window.
Right.
And as I often tell those who come to me, do not forget that I make money from it. So if I'm advising you not to do it, it cannot certainly be for my own benefit. It is for your own benefit. And
Yes.
so as to prevent other chats, discussions on the chat, the
Yeah.
men must know that when you go for a PSA test, ultimately, if we detect you have prostate cancer, are you prepared to be impotent at the age of 55 when you had no other symptoms than you simply felt like you should give yourself a treat, and instead of going to buy yourself a nice bottle of Coke, you went to have a prostate cancer, a PSA test done, and you come to me and I say, well, I'm going to do radical prostatectomy and radical radiotherapy, you'll be impotent, you may be leaking urine and all that. Those are the real truths.
Yes,
So
that's very true, sir. And I think that this has even led us into the Q&A session, because there's a question and Q&A box that says, if we are not to do PSA, as you have said, routinely, is there any other gold standard for testing or for screening, or should we not even be screening at all for?
No, we should. For prostate cancer, like I said, we urologists have come out in all associations to say no to prostate cancer screening, but yes to early detection, which is why I showed in my last slide, if you have a problem with your urination, go to the doctor early.
Okay, sir. So what we need to look out for would be problems in urination, problems
or any
with...
other. Once you have, like has been said by my colleagues, once you notice any body change,
Okay.
go and see a doctor.
Okay. Thank you very much, sir. I think I'll just take some of the other questions because our time is fast spent. But I must also thank all the participants that have been with us from the start, even till now. We still have a huge number of people still on this webinar, which proves how important and how educative that the webinar has been. So I'll just go to some of the questions now. So there's a question that goes, is there any sign that signifies early cancer of the rectum or other internal organs like pains, etc.? So this person is asking if there's any sign for cancer of the rectum. I don't know if Dr. Showmi can quickly take that question very quickly.
Okay, thank you. The truth about it is that, like having said by all the speakers, if you notice a change in bowel habits, Dr. Sharia talked about the caution sign, something that it's persistent for over a period of time, and it's important you go and see your doctor, and so that you will have a comprehensive investigation, you'll be checked, and at the end of the day, you'll be able to detect. If there is nothing, then your fears will be allayed. But if there's something, at least you can start treatment early. But usually for rectal and for the colon, you have change in bowel habits. And at times you can have bleeding while, doing number 2, depending on the level where the rectal disease is. Because the rectum is the lower down. For those, not for you, a doctor, but for those who don't know.
Yeah. Yes, exactly. Thank you, Dr. Shomi. This is a very interesting question I'm about to read out. He says, can one be inflicted by more than one type of cancer at the same time? For example, can someone have colon cancer and prostate cancer at the same time? Prof, do you want to answer that question for us, sir?
Yeah, indeed, that's actually the problem. So it's why I insist that the patients or patients should always go to a doctor, because apart from what has been said, it should be obvious that a lot of the signs of cancer are similar wherever it's coming from. So sometimes it is a dilemma to even identify where the cancer is coming from. And it's also not unknown for us to be focusing on one cancer only to find out that the patient has what we call a metachronous cancer, which is another cancer shooting up somewhere else. So the answer is yes. You can actually, any patient can actually have more than one cancer. I have had a patient who had 4 cancers going on at the same time. And it was important that we decided what was what. And in that particular patient, just as a teaching point, there was an emphatic issue on the fact that there was an emphasis on the fact that he had prostate cancer. And I kept telling them, prostate cancer doesn't do this thing that you are talking about. But his family was so fixed on the prostate, they took him to London, they did all sorts of funny things. By the time he came back, we found out that he actually had bladder cancer, and he died of bladder cancer. But he actually went to London, spent hundreds of thousands of pounds, and they were treating the wrong cancer. So that is why the issue is you should go to a doctor and be thoroughly examined, so that not only do they find out what cancers there are, they actually find out which is the one causing trouble. It may not be the one you are seeing.
Yeah, okay. Thank you, sir. So there's a concern here. Someone has posted a question on the chat box, says that just before their cycle, I reckon that this is a female, that her nipples itch a lot. She says she has had a mammogram done before and nothing was seen. Is this normal? Dr. Showmi, do you want to let us know if this is normal?
Yes, it's normal. Like usually we say when you want to examine your breasts that you don't do it until a week after your menstrual period, simply because about 10 days or 2 weeks to your menstrual period, you have, because of the hormonal changes, you have fluid accumulation. So your breast could be very painful. The nipple, there are times you even wear your bra, you find out that even the bra irritates you, causes more pain. And so because of that, then at times it's itching, you can have anything. So most times it's important that when you have such symptoms, wait until your periods are over and then a week after. But if, like we say, if it continues over a period of time, then, go and see the doctor for a thorough check. But it's normal.
Okay, thank you, Dr. Showmi. I hope that has allayed any of the fears that that the person who posted this might have had before now. Just a final question from the chat box. I have a question of my own and I'll take it last. But we have a question from Yemisi Ayeni, and the question is, what is the percentage of cancers that are caused by lifestyle or genetic history, or maybe a third option, which is maybe unknown or random, something that is random? And do these percentages vary significantly between the types of cancers? So what causes it? Is it lifestyle? Is it genetic history? Is it random? And this person has said that they've known many people who have had cancer, and all of them fall under the third category, which is that it's not caused by lifestyle or genetics, it's random. So if this experience is not unusual, does it mean that majority of cancers cannot be prevented and we should focus on just screening and early detection? So essentially, just to summarize this question, like how I think I understand it is to say, it seems as though most cancers are random and you can't prevent them by lifestyle or by genetics. So should we just focus on early detection alone? What is your take on that, Prof?
Actually, the truth of the matter is that 60% of cancers are all from diet being food and lifestyle. If you remove, if it were possible for us, as my colleagues have said, to go back to the good old days of eating properly, not eating processed foods, exercising properly, because diet encompasses everything. Having alcohol in reasonable quantities, no tobacco, 60% of cancers would not occur. Another 20 or so percent are genetic, as Dr. Shagaya had gone on to say, and it is not even single genes, it's multiple genes, as I think I had in my discussion with you. So rarely, sporadic cancers are not the most common. They are just the elephant in the room, in the sense that they're the ones that you do not know where they're coming from. So they are the ones that screening is targeted against. If we know what is the cause of a cancer, then it is no longer needed for screening. Just go and stop the bad habit. So that's not that's the prevention. So screening is for those sporadic ones, and that's what we concentrate on. But really and truly, majority of cancers are from diet. If we had a good diet, which encompasses all I said before, the cancer incidence will certainly drop.
Wow. Okay, that's great. That's great information, because that means that if we can all focus on diet, eating a healthy, balanced diet, fruits and vegetables, stopping smoking, reducing alcohol, we all have reduced our risk factors for getting
exercising.
and exercise.
Yeah.
All right, thank you very much for that. There's just one last question I'm going to squeeze in from the chat box. Someone is asking if there's any way one can reduce the risk of a benign tumor from becoming a cancerous tumor. Perhaps they found a benign tumor in their breast or somewhere. Is there anything they can do to prevent it from becoming a cancerous tumor? Is there anything like that? Dr. Shomi, do you want to take?
Okay, there's nothing that can be done. The truth about it is that most times when you have benign, it's benign. There are very few cancers that transform from benign to malignant. So once you see, but the guideline or the principle is that if you see any lump in your breast, it's important to remove it, whether it's benign or it's malignant. So the only thing is that when it's benign, I mean, your fears are allayed, gives you, but it's important to remove it. But most times, you know, a lot of cancers really don't go from benign to malignant. Some do, but most of the time they don't. So
I think I would just question here, because we know that there are some women generally tend to have lumpy breasts, and most of them are benign, right? And those lumps can be a lot. Do they remove all those lumps? Because that might end up disfiguring the breast. What is your take on that? Because a lot of women do have lumpy breasts, and you know, it's just their regular natural makeup. What do you think about that, ma'am?
When you do, that's why it's important to do investigation. A lot of people have lumpy breasts, especially in the Blacks. We also talk about dense breasts. So when you do your mammogram or you do your investigation, if there's nothing there, there is no need for it to be removed. But when we talk of removal, that is, you see like a solitary, obvious lump amidst the lumpy breast. So you don't need to remove, if your breast is lumpy, once you do investigations and there's nothing there, then all you do is just sit back and do your regular, you know, screening as indicated. That's all.
Thank you very much, Dr. Shomi. We are going to close off this Q&A with one question from me. And I've had an experience of a very close aunt of mine who died of cancer last year. And I remember that it was very difficult getting radiotherapy treatment for her. She went from Zaria to different places. She came in from Ife, but she had to go to Zaria, and then we had to come and queue in Luz. But that was many years ago. I'm very happy to hear that there's been an upgrade in Luz now, and there's a beautiful cancer center, the radiotherapy center, and you've said that is the best in West Africa. That's fantastic. Yes. There is some development, because I remember then you were all there, and sometimes the equipment will break down and all. But I know that we have started, but we are not close yet. And the president in her speech mentioned that we have less than 10 radiotherapy centers for 200 million people. How many centers do we need to have to be able to contain or fight this scourge of cancer in Nigeria? And how do you think we can get it? Prof. Sir, would you help us with closing that out, answering that question and closing it out for us?
Yeah, just to take privilege of a speaker. The issue of benign going to cancerous, there is only one great exception, which is colon cancer, which is the exception that makes the rule, which is why we would always remove so-called benign polyps from the colon. But that's the most prominent exception, so that people do not go away thinking that none does so. But Dr. Shomi is absolutely right. Most benign tumors don't become malignant. As regards what we need, we have 200 million people. If you have 30, you would not be serving our population, because a lot of diseases that we say we don't have is because we don't look for it, and because we don't, like I said, we haven't even done the population studies to even find out what the prevalence of all these cancers are. But overriding that is ensuring that we have the staff and the expertise that will run those centers. There's absolutely no point having a world-class radiotherapy or world-class oncology center that has no staff. And this again goes back to why you cannot simply pick one aspect of the system and then think you can fix it. You really have to start from the foundation up. We must ensure that we have homegrown policies on how we are going to grow our oncology treatment, which is the same thing as growing any other treatment. It's the same problem without being an expert that happened with Ajaokuta. They built Ajaokuta only to find out that not all the engineers in Nigeria will be able to staff Ajaokuta. What is worse, Ajaokuta was providing rolling round steels, whereas what we needed were flat sheets of steel. So we ended up still importing. This is why we must really ensure that we have information of our own from research before we go ahead and do anything. 200 million people, 50 radiation oncology centers, or 50 oncology centers will not be too much, but can we staff it? Do we have the ability to provide the consumables? Do you even have the power? Is it on 9 megawatts of power that you are going to run oncology centers? It's a multitude of things that we need to actually address, which is why I end by saying this is where the Institute of Directors comes in, because the directors are directors from all sectors of the economy, and they should realize that they all interdigitate. And I close with some figures. As you've noticed, I try and avoid giving full figures because we don't really have real figures, but we have some figures. If you put $1 into roads, you get $3 back. If you put $1 into ICT, you get $5 back. If you put $1 into nutrition, you get $17 back. If you put $1 into education, you get $13 back in terms of national development. So the IOD needs to understand that what we're talking about is to their benefit, because if they have the ones in charge of the infrastructure as it is, and they provide the infrastructure and engage with the other sectors to provide the expertise, which is the training centers, that is when it will function. We are better off having 3 functional radiotherapy centers than 25 non-functional radiotherapy centers, which is what we always end up with in Nigeria.
Oh, wow. Thank you very much, Prof. Thank you so much to the amazing speakers. Today was really enlightening, educating, inspiring as well. And just to wrap up, I want to thank the leadership of the IOD again for giving us the opportunity to bring together the best of the best that we have, who have really opened our eyes on these issues that have to do with cancer. And just as a wrap up, as we said before, take caution, know when to see your doctor, know when to have your checks done, but also if you're a director or you're in a place of influence, know the things you can do to improve the incidence rate to stamp up the scourge of cancer in Nigeria. Thank you also to all the participants for staying for the entire webinar. I'm sure that you really, really enjoyed it as I did. Just to close us out, I'm going to invite the Director of Academy, Mr. Sunday Adenipeku, to give us the vote of thanks and the close. Thank you, everyone.
Thank you so very much, Dr. Itunu Akinwari. On behalf of the Institute of Directors, Nigeria, I'd like to say a big thank you to, first and foremost, the President and Chairman of the Governing Council of the IOD Nigeria, who is the chief host of this program, and ably represented by our first Vice President in the person of Alhaji Tijani Borodo. A lot, was said to set the tone for this program. I want to seize this opportunity to thank you for being there all the time. And of course, I cannot but thank, very immensely, Mr. Nandi Okafor, who is the chairman of the Health and Social Security Committee of the Institute. It was this committee that is very instrumental in putting this program together. Of course, we all agree with me that this has been most beneficial. Honestly, personally, my eyes have been open to a lot of things that I didn't know before, or that wrong impression that I had. And one can only be better for it. And that goes for virtually all of us that are on this call. So, sir, we want to use this opportunity to thank you very profoundly. We appreciate you for steering this program. I cannot but thank again on behalf of the Institute this very formidable panel of consultants, specialists, oncologists, urologists that are, makers of men and savers of lives. Of a truth, they have come to this program with their hearts poured out. I wish we had more time. I mean, if we spend like 5 hours on this, we'll still be talking. But of course, they have really triggered a lot of inspirations in us, and they have told us what to do. We want to use this opportunity to thank each and every one of you for finding time out of your busy schedule to come and disclose what has become very impactful, very educative, and very insightful to all of us. We really appreciate all of you. Thank you so very much. I'm going to believe that when we invite you next time, you will still come. You have challenged IOD as an institute, and of course, we'll go and do something about that. I mean, at the institute, I can assure you, our principals are here, and I'm sure a lot will be done with regards to the challenges that you have put to the institute. At this juncture, let me appreciate especially all our participants on this program, all the attendees. Of course, I look at the number of participants. Since the beginning of the program up till now, all of us are glued to the program. It really goes a long way to show, the importance of this program. Health is wealth, and the importance we attach to it, and the fact that the disclosures are very, very needful. So I want to thank all of you for registering and for coming. And look, all of us are gospelers. We are evangelists of all the messages, all the truth that we have learned on this program today. Please let us spread it. There is none of us that have not had maybe one relation or the other that have had cases of cancer, if we are not experiencing it directly personally. I have a relative that died just like 3 years ago of cancer. So it's a very important subject that we need to continue to spread the awareness among people, our neighbors, our relations, and all that. It's very needful so that we can save more lives. More importantly, distinguished ladies and gentlemen, I must appreciate profoundly Dr. Itunu Akinwari, who has moderated this program today. Highly professional, spot on. The summary, I don't need to summarize anything again, because of course my note is full here, but she captured everything. I want to thank you, Ma, for creating time to moderate this program. Of course, you have done a very good job. And if I saw one of my friends who says that the punishment for that would be to invite you to do to come for such another role. Thank you very much, Ma. We really appreciate you. On behalf of IOD Nigeria, I want to please plead with all of us, to continue to spread the truth that we have learned on this program, and to attend other programs that IOD has subsequently in the remaining part of the year. Of course, if you are not yet a member of IOD, this is an opportunity. This is just but the list of what directors benefit becoming members of IOD. If you are not yet a director, please tell your directors and other eminent personalities around you, the need to become members of this institute. All of us have a lot to do together, even as we benefit from, forums like this. Once again, I thank all of you, and I pray that with divine hand of God and all that we can do as human beings, we will stem the tide, of common cancers in our domain. Thank you so very much. Enjoy the rest of the day. Thank you. I guess now we can take the